So investigating sleep apnea, we will look at different ways of investigating the sleep disorders. The presentation is supported by Teva Pharma Australia. I personally have received honorarium from pharmaceutical companies and device company for educational events, as well as research grant from AstraZeneca. To begin with, sleep disorder breathing is common in a society. It consists of several separate disorders, within which obstructive sleep apnea is the most common type. There is also central sleep apnea and sleep-related hypoventilation disorder. If we take a very conservative approach of defining sleep apnea as an AHI of more than 5 events per hour with symptoms, then the prevalence of OSA is probably around 15 to 14% in the male population and about 5% in the female population. Despite the fact that each of these disorders may have distinctive symptoms and physical examination finding, the diagnosis does require formal sleep testing to fit in the criteria. To understand obstructive sleep apnea, it is a repetitive collapse of the upper airway during sleep. This could include both apnea, which is cessation of airflow, and hypopnea event, which is reduction in airflow. The definition by the ICSD-3 defined that OSA is a polysomnogram determined obstructive respiratory disturbance index more than 5 events per hour. This has to be associated with typical symptoms such as unrefreshing sleep, daytime sleepiness, fatigue, or insomnia. And if we don't have any symptoms at all, then we can take it as an obstructive RDI of more than 15 events per hour. Currently, we can use screening questionnaire as a way to help identify patients who are at risk of developing sleep apnea or currently have the symptoms of sleep apnea. So we can use screening questionnaire as a way to identify patients who are potentially at risk of developing OSA or currently have symptoms such as OSA. The Berlin questionnaire in the top right is designed and validated in the primary care setting and look at 10 questions that's present there to identify the risk. And it put the patient at either high risk or low risk depending on the result. The stop bang score on the bottom right is also designed again in the primary care sleep clinic setting to look at symptoms together with the characteristics of the patients. And that categorizes into either high risk, intermediate risk, or low risk. And the OSA 50 questionnaire is more simplified using 4 different parameters to assess the patients. And again, out of a 10 of a score, with 5 or more considered such as of high likelihood of OSA. There are otherwise subjective measures of daytime sleepiness. The Epworth Sleepiness Scale has been frequently used as a tool. It provides 8 commonly encountered scenarios to give you a score out of 24. And the higher the score, it indicated the greater degree of daytime sleepiness. But it's important to note that when we're using the Epworth Sleepiness Scale, that the score does not correlate well with AHI, as there are patients who may be significantly tired during the daytime and have other reasons other than obstructive sleep apnea that can cause the daytime tiredness. When we look at investigating sleep studies categories, then under the AASM criteria, there are 4 different types that we looked at. Type 1 is the attended in-laboratory full polysomnogram, whereas the type 2 to type 4 are usually unmonitored home-based sleep studies. For the type 1, this is the reference or the gold standard, and it usually have 7 recording channels or more, measuring sleep stage, breathing and cardiac parameters, and limb movement. And you can further personalize this to have either more EEG leads, especially if you're looking for seizure activity. You can look at additional of TCO2 monitoring to look for the hypo or hyperventilation disorder. And we can furthermore add other channels like video webcam, etc. As per needed. The type 2 unattended home full PSG can also have more than 7 recording channels. And we'll discuss those to type 2, type 4 in subsequent slides. So in diagnosing OSA, polysomnogram is very important as a rule. The current reference standard is the in-laboratory full polysomnogram, which is a type 1. and the sleep technician is attended throughout the night. This should be accredited against ASM criteria, which defined hypopnea as changes in flow associated with 3% oxygen desaturation or cortical arousal, or 4% oxygen desaturation without consideration of cortical arousals. And this criteria set the way for us to assess the presence or absence of obstructive or hypopnea events, and therefore categorizing the type of sleep disorder breathing the patient has and the severity. So for type 1 PSG, the pros is that it allows real-time monitoring in the presence of an attendant, which means that if there is any significant problem during the night of study, that can be rectified. It can also determine need for supplemental oxygen. It can be allowed to facilitate a CPAP or NIV titration and allow PCO2 or monitoring as well as other seizure or parasomnias by personalizing the testing and the parameters that we are testing, and you can have more monitoring channels. But related to this becomes labor intensive and costly. And patients usually also complain that this is not their usual home environment, which for some patients, they may affect their ability to fall asleep or have a prolonged sleep time in bed. And because it is an in-lab facility, it is limited in availability, and during the current COVID situation, we certainly have been affected by it. This is a typical graph showing a 30-second epoch on the left and the channels that is being recorded and displayed for analysis. And the setup of the patient you can see is on the right, bottom right, and on the top right, a schematic demonstrating the minimum channels that usually will be recorded. This includes the EEG leads, the EOG leads, which allow us to facilitate them better recording and identification for slow wave sleep, for REM and non-REM sleep, and also for the airflow, the EMG, chin EMG, the microphone for snoring, the positional belt that usually help us to identify the sleep position, and also the thoracic and abdominal wall movement, and ECG and a pulse oximetry. So for the type 2 sleep study, which is a home sleep apnea test, this usually is convenient and performed in the home environment for the patient, which will be much more suitable for patients' comfort and flexibility. It usually monitors a minimum of 7 channels, but not necessarily the EEG channels. And therefore, it can underestimate the severity of sleep disorder and breathing disorders, as well as not able to determine a hypoventilatory disorder, or in the event where there's significant cardiopulmonary diseases where we're looking for chain stroke breathing. It is also not suitable for patients who've got severe physical disability or in the environment that is not suitable for sleep. This meta-analysis published in 2009 compared between the two types of studies and be able to show that both does provide similar diagnostic information, but it does underestimate severity of AHI by approximately about 10%, with significant cheaper cost. In terms of the Medicare ruling, this has been changed recently to reflect this. GPs nowadays can refer directly eligible patients for diagnostics home-based sleep study. This does require that the patients had to satisfy a criteria that would determine the eligibility. This included using those screening questionnaire that we suggested before, where there's a stop bang score of more than or equals to 4, or OSA50 score of more than or equals to 5, or high-risk OSA determined by the Berlin questionnaire. And the patient also have to demonstrate a degree of daytime tiredness with an Epworth Sleepiness score of more than or equals to 8. Patients who are then suspected to have moderate to severe OSA can then be referred to a qualified sleep medicine practitioner for further investigation, either through a diagnostic or home-based sleep study. Regarding type 3 and type 4 sleep studies, these usually have less variables that is being monitored. Type 3 tends to have more, usually about 4 variables, typically the oximetry plus respiratory effort, airflow, perhaps head or body position, or ECG, actigraphy, and sound, whereas type 4 usually only monitors saturation, heart rate, or airflow, which is only 1 or 2 measured parameters. They are unable to usually determine the duration of sleep, the arousal or sleep stages, nor detect non-respiratory type of sleep disorder. They are not reimbursed by Medicare, and they may have a role in suspected severe OSA or perhaps as monitoring, but not necessarily in the investigation of sleep apnea. So now we come down to actigraphy. There are a lot of new models nowadays on the market, such as wrist actigraphy, which uses a accelerometer to measure wrist movement, and in so doing, assess sleep or waking state. Whilst they are very popular, they actually have very limited validity to assess sleep. They are perhaps good to look at time in sleep bed or total sleep time, and perhaps help the patient understand the sleep pattern better. But majority of actigraphy on the market overestimate sleep and underestimate wake time. So to understand the role, these are a typical component of the sensor set that is now in our smart devices. There are three main sensors in our smart devices to measure motion detection: an accelerometer, a gyroscope, or a magnetometer. The accelerometer detects changes in the device displacement, orientation, and tilt across those three axes, whereas the gyroscope measures just how fast the device rotates along the three axes, and the magnetometer measures the strength of the magnetic field around the phone. So in measuring the changes of acceleration, the accelerometer aim during the sleep is to measure whether there's movement and therefore predict whether the patient is in different stages of sleep. So in this slide, we explored a comparative study between the reference PSG to 5 different wristwatch actigraphy devices. They compare between the total sleep time, sleep efficiency, light sleep, and deep sleep, determined through the accelerometer about the patient's movement. The blend almond plot measured the x-axis, which is the mean between the two devices, and the y-axis, which represents the differences between the polysomnogram and the device's result. And through there, you can see that most of the actigraphy devices are pretty good at looking at the total sleep time and perhaps a degree of sleep efficiency, but it varies between the light and the deep sleep to try to determine the movement of the patient. And next we're talking about is the sleep apps. They perform a broad range of functions, including sleep alarm clocks, sleep aids, and sound recording during sleep and sleep analysis. There are a large number of sleep apps on the market. The one that most reviewed tends to be Sleep Cycle and a few other different brands, including the Sleepbot. So majority of the app may not necessarily record sound, but it does offer and work mostly as a sleep aid. Some of the apps does not provide sleep structure data, but just measure the amount of movement by the user during the sleep. So all of them tends to record sleep duration, relying on the accelerometer, which is highly sensitive but poor specificity in terms of different stages of the sleep. And comparative data, we found that there is no significant correlation between the PSG finding and the sleep app with regard to sleep efficiency, light sleep or deep sleep percentage, or sleep latency, but they are mostly good in detecting sleep-wake differences, but they just have poor specificity. Lastly, I just wanted to look at central sleep apnea and other hyperventilatory disorder. Central sleep apnea are repetitive cessation or decreases of both airflow and ventilatory effort during sleep. It can be primary or secondary. And these are predetermined ASM criteria. So if we want to look at the presence of sleep hypoventilation, we would like and need to measure the transcutaneous carbon dioxide level, which is a surrogate measurement by looking at the skin and surface transcutaneous CO2 and O2 level to provide an estimate of the PaCO2 and the PaO2. And by measuring the transcutaneous TCO2, we can then determine whether there is an elevation to more than 55 millimeter mercury for at least 10 minutes during sleep, or an elevation of 10 millimeter mercury above baseline value. The last usage for lab-based PSG will be looking at titration study. So these are usually performed to determine the optimal CPAP or bi-level PAP pressure setting required to resolve the obstructive or the hypopnea episodes. A split night PSG really is just a sleep study that has a diagnostic phase and a PAP titration phase if the obstructive event is present during the sleep. The diagnostic portion, if we're looking at sleep night, should be more than 2 hours, whereas the PAP titration portion should demonstrate elimination of respiratory events during both REM and non-REM sleep. So the con of using a sleep night study then is that there could be individual variability during the night, and also the lack of REM sleep in the start may underestimate the severity of OSA. So in summary, PSG is gold standard in qualification and quantification of sleep disorder breathing. The gold standard does require monitoring of a number of physiological signals. It provides report on number of apnea, hypopnea, and derived variable to assess the nature and severity of the sleep disorder breathing. And current Medicare rebates type 1 and type 2 sleep study, and there are very clear eligibility criteria that needs to be fitted. Current smartphone application and wearable devices are highly sensitive to sleep duration and can measure snoring, but not so to other physiological sleep parameters. So thank you for listening to my talk, and this is the reference, and I'm now going to hand over to Dr. Amy Reynolds for her talk.